Hi, this is Brian Kim. I want to share with you case number 227 in the Best Way to Do Cataract Surgery series. And again, the title of this series is not to say this is the best way, but to encourage all of you to think about your best way to do cataract surgery, which means you have to think about every case. Every case is a learning experience, and hone and refine your technique to provide the very best for your patient. And so this is a dense white cataract. I want to put Trypan blue on the surface, and then you're going to see terminal chop and cross chop, and then leveraging mechanical fracturing forces to safely disassemble the lens, as opposed to using traditional lens disassembly techniques. I'm using a cotton tip to center the eye, and then use a corneal marker, which will help me to center and size the rexus. And this is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some intracameral air. You want to decompress the chamber as you put that air in. As you decompress the chamber, you can get a bigger air bubble. And this is the Trypan blue. I'm very carefully painting the anterior capsule surface with the dye. Now, oftentimes with this situation, you have a dense lens, you might have some weak zonules, so the chamber will tend to collapse, which is, again, a very understandable and predictable thing to occur when you're trying to paint the dye on the anterior capsule. And this is the dispersive viscoelastic. I'm going to push the air bubble out as well as push out the dye, and then coat the corneal endothelium and flatten the anterior capsule with the viscoelastic. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, using the cannula to help turn the eye away from me, tunneling through the cornea, turn the eye towards me, using the cannula to help control the eye, and then I enter. So I use a cannula in the second instrument a lot when I do cataract surgery. And this is the sharp tip microforceps. I'm going to puncture the center, pull down towards me. You can see I have excellent control. I don't have very much radialization forces as I'm doing the rexus. And this is my current technique in performing capsular rexus. So this is the capsule fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally. And again, with these lenses, they tend to be very soft. Peripherally, it's very fluffy, and it doesn't tend to be stuck to the bag. And so I'm not surprised that the lens was able to spin rather easily in this case. Coating the surface of the cornea after irrigating the surface first, using the dispersive viscoelastic. I did the coating of the cornea backwards. I normally do that after I finish the capsular rexus. So I go ahead and begin to sculpt. This is in the dense setting mode. I'm going to sculpt a trough, and I'm trying to essentially debulk the central core so that I don't encounter that posterior plate phenomenon. Again, I'm not trying to go down to the posterior capsule. I'm just trying to remove and cut that dense central core. Turning the bevel down now, and this is the terminal chop. I'm placing the chopper contra-incisionally, and I'm hooking the peripheral lens. And this is in typical chop technique, but look, I have the phaco tip deep within the lens material, right? Between the lens material, and therefore I'm able to fracture and cut that terminal edge, and once I start to spread, that crack propagates all the way through and through. I place the chopper under the right heminucleus, hooking the peripheral lens. Again, I'm able to flank the lens with the chopper on the right side and then the phaco tip on the left side. By positioning the instruments this way, I'm flanking the lens, and I'm able to pull centrally with the chopper. And as I pull centrally with the chopper, it cuts the lens against the phaco tip, and the phaco tip is acting like a chopping block. I go ahead and place the chopper around that first quadrant, and I perform another cross chop maneuver, cutting the lens piece again in half, and then using mechanical fracturing forces to crush the lens pieces into smaller pieces, and then emulsifying the lens piece. Placing the chopper around the lens, again cutting the lens in half with another cross chop maneuver, and then using some vacuum to grab the lens piece, crushing it with mechanical forces, and then emulsifying the lens piece. Turning that second heminucleus in front of me, placing the chopper around the lens, hooking the peripheral lens, pulling it centrally toward the phaco tip, again crushing the lens in half with another cross chop maneuver. You can see there's a little bit of a posterior plate phenomenon here, but look what I do. I just very carefully with irrigation alone, I get under the lens with the phaco tip. You see that? Again, you would never do that with traditional techniques. Why? Because you're used to using vacuum with the phaco tip, but you don't have to. Don't use vacuum, don't use ultrasonic energy, and you can get under that posterior plate piece, that leathery piece. I got under it with the phaco tip, and then I crushed it with the chopper. That was a beautiful illustration of being able to position the phaco tip deep safely, since you're not using ultrasonic energy or vacuum with the phaco tip. In that moment, the phaco tip is acting as a cutting, fracturing instrument, not utilizing it for vacuum or ultrasonic energy. So position that chopper around that last quadrant, and then crushing it against the phaco tip with a typical cross chop maneuver once again, and then using some vacuum to grab the lens pieces, and then crushing the lens into smaller and smaller pieces, and then emulsifying the lens piece. So again, this was a dense white lens. It wasn't a hybrid mature. There are clearly some leathery components to the posterior aspect of the lens. You saw I was able to get under the lens with the phaco tip, again, using irrigation only, and very carefully being able to get under it and then crushing the lens with the opposing forces of the instruments. And essentially doing the same thing again, positioning the instruments around the lens piece, flanking it, and then crushing it into smaller and smaller pieces, and then very carefully emulsifying the lens piece, making sure that the phaco tip is away from the posterior capsule, and or making sure there's lens material between the phaco tip and the posterior capsule. That's another thing I do. I don't talk about it a lot, but I do it on every case. I always try to make sure when I am emulsifying the lens pieces that there is another lens piece between the phaco tip and the posterior capsule. And that's just good technique. You want to be able to kind of keep your phaco tip more shallow away from that posterior capsule and keep a lens piece acting as a wall to protect you. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. You'll notice here I have the purple sleeve. And why is that? Because in the beginning, I already decided that I'm going to be putting a 3-piece lens, and the 3-piece lens requires a bigger incision. And so therefore, I'm using the purple sleeve. The purple sleeve is for bigger incisions. And so my incision in this case is more like a 2.83 millimeter. And why is that? Because the MA60AC lens goes to a bigger incision. And rather than widening the incision, and why do I not like that? Because, you know, you've seen my previous cases when I widen the incision, then I go in with the INA, and what will happen is the chamber is going to be very unstable and collapse. And I did have one case when I went in with the INA, the chamber collapsed, and then I ended up rupturing the posterior capsule. And so it turned out okay, but why do that? Why, you know, put yourself in that situation? And widening the incision and using a smaller sleeve and having all that viscoelastic and then the BSS coming out, it's just not a stable chamber situation. It's better to have good incision and phaco sleeve matching rather than, like I said, widening the incision and having a mismatch there. So you saw I removed the cortex, which again, there wasn't that much anyways. And then I started to polish. You can see there's some lens material in the subincisional space. I'm using the BSS cannula to pulse into the subincisional area, and I'll be able to efficiently remove some of that lens material, again, using coaxial INA, using that polymer tip. Disengage the irrigation fluid, and then filling the capsular bag with cohesive viscoelastic. And then I'll go ahead and polish with the sweep. And you can see there's some lens material that's there in the subincisional area. This also cleans the lens epithelial cells away. I'm able to go with the same incision. In this case, it's a little bit tight, but that's okay. I'm using some cohesive viscoelastic to push and stabilize the chamber, and I use the two-handed technique to kind of squeeze the injector through the incision. The leading haptic is coming out into the capsular bag now. I asked for some more viscoelastic, so I go ahead and push some more viscoelastic to fill the bag. With the three-piece lens, especially, you don't want to have a decompressed bag when you're putting the lens in. You don't want to potentially cause posterior capsule rupture with the haptics. Go ahead and deliver the optic, and then dial the trailing haptic into the bag. So again, by doing it this way, now look, I have good matching of the incision with the sleeve. I don't have tremendous amount of fluid egress. I don't have iris trying to prolapse. And, again, when the chamber starts to collapse, when I get underneath the lens, I don't have to worry about anything dangerous to happen. Again, in the past, I had that one case where the chamber collapsed when I tried to get underneath the lens, and it did cause a posterior capsule rupture. It's, again, tricky when you're dealing with these cases. And these are all things you need to think about all the time. You got to think about these different steps. And so my newest thing that I'm doing is, if I'm going to go with the three-piece lens and I know that I'm going to have to widen the incision, don't go with that smaller incision. Go ahead and use a bigger incision, a bigger blade, and use that bigger sleeve, the purple sleeve in this case. And I'm able to place the injector in without widening it. Therefore, I have good matching of the sleeve to my incision, and I don't have to worry about chamber instability at the very end of the case. Again, why would you want to have a perfect surgery that's executed and at the very end end up having a problem? Just go ahead and hydrate my incisions, and that's really the end of the case. And so again, this is a white, dense cataract, had a little bit of a posterior leathery adhesion there, and I did perform the terminal chop, debulk the central dense core, again fracturing from the terminal side, propagating that fracture all the way through and through, and this again bypasses that posterior plate phenomenon. I performed cross chop maneuvers throughout the case, and then using mechanical fracturing forces to keep the CDE down, and using and leveraging mechanical fracturing concepts, hooking lens pieces up out of the bag rather than going after lens pieces with high vacuum and then pulsing it and trying to get purchase and pulling them up out of the bag. Again, very risky and dangerous. You're really getting really close to the posterior capsule with high vacuum and ultrasonic energy when you're doing that. Why try to prolapse lens pieces up with the phaco tip? It makes no sense. Just go ahead and use a chopper to pull lens pieces up. Use mechanical fracturing forces, flank the lens with your instruments, crush the lens into smaller pieces. By doing it this way, you use less ultrasonic energy and vacuum. You'll have clear corneas post-op day one. A much more efficient, and again, in my opinion, a more elegant way to disassemble the lens, especially in this dense white cataract. So I hope this was helpful to you, and I thank you for your attention.